Good afternoon and welcome to today's webinar. This is the first in our three-part TTAC webinar series, beginning at the beginning, the foundational elements of early childhood mental health consultation. I want to thank you all for joining us today. My name is Meg Beyer, and I am the Assistant Director of Strategic Operations at the McSilver Institute for Poverty Policy and Research, and I am one of the partners for the TTAC project. And I'm really thrilled to be with our presenter, my colleague Evelyn, who I'll introduce in a moment, and with you all who are joining us today for the webinar. Before we get started with our content today, I wanted to just review a few logistics before we dive in. So for those of you who may have joined us for a TTAC webinar in the past, this will all sound very familiar to you, but if this is your first time, just a few pieces of detail that might help with your TTAC webinar experience. So as we've done in the past, this webinar is going to be recorded and it will be posted along with the slides to the TTAC website. So we just ask that you stay tuned for an email that'll announce when those slides and recording is available. We will be taking questions throughout the webinar today, so that we ask that you chat in your questions by using the chat box functionality, which should be located on the right-hand side of your screen. And we're asking that you select on the drop-down, there's a little arrow to the right-hand side that says, click the drop-down, click all panelists, and chat your questions in that way. That way all the panelists and presenters can see the questions that come in that we collect. We do have time at the end for the questions, so we'll try and address as many as we can. But if not, don't worry, we collect all questions, whether they're answered or not, and we do our best to respond to them as best we can. For those of you who may be LMSWs or LMHCs and are interested in obtaining CEUs, we are offering them for this three-part webinar series. However, you must attend all 3 webinars in this series to receive the CEUs. Further information on how to obtain the CEUs will be distributed via email following the webinar series completion. So stay tuned for more, but just know that if you're an LMHC or an LMSW and you'd like CEUs, you do have to attend all 3 of the webinars. Finally, towards the end of our webinar, we are going to be sending out a link to a feedback survey, and we'll be chatting that out to you in the chat box. We ask that you click the link that's shared in the chat box and complete the feedback survey. It doesn't take much time. There's just a couple of questions, and we really appreciate all the time that you would take filling this out, just because it does allow us to understand your experience and to enhance our future TTAC offerings. So with that, I want to again thank you all for joining us. I'll be back to remind you about the feedback survey towards the end of our webinar, and I'm going to hand this over to my colleague, Evelyn Blank, my colleague from the New York Center for Child Development. Thanks, Evelyn.
Thanks. Thank you so much, Meg, and I'd like to welcome everybody to part 1 of our 3-part series today. And my name is Evelyn Blank, and I am the director of the New York City Training and Technical Assistance Center, otherwise known as TTAC. TTAC is funded through Thrive NYC in partnership and collaboration with the New York City Department of Health and Mental Hygiene. TTAC is a partnership between the New York Center for Child Development, my agency, and the McSilver Institute on Poverty Policy and Research. New York Center has been a major provider of early childhood mental health services in New York, both through informing policy, but also supporting early childhood mental health through both training and direct practice. And we are very privileged to be subcontracting with NYU McSilver Institute for Poverty Policy and Research. They house the Community and the Managed Care Technical Assistance Centers, otherwise known as CTAC and MTAC, and they offer clinic, business, and system transformation support statewide to all behavioral health providers. And I just want to say this has been an incredibly robust partnership, combining our clinical expertise with McSilver's technical assistance. TTAC is tasked with building the capacity and the competencies of mental health and early childhood professionals through ongoing training and technical assistance. And I just want to briefly just direct you to our website, which can be an ongoing resource for all of you. And if we go to the next slide, you will see the link and the actual screenshot of our website where you can go to learn about upcoming events that are happening. We also archive our previous webinars and past presentations and also add additional resources. And I will note that we've also added some resources around COVID-19 on the bottom that includes some guidance documents as well as an archived webinar and another upcoming webinar. So it is now my privilege to introduce Kadija Johnston, who is a clinical social worker who's been a practitioner in the field of infant and early childhood mental health since 1985. For the past 15 years, she has been the director of the Infant Parent Program at the University of California in San Francisco. She developed an approach to early childhood mental health consultation that serves as a model for other organizations locally, nationally, and internationally. And I want to say that in this sense, she has been a true pioneer and a leader in the field of early childhood mental health consultation. She has provided technical assistance and training in early childhood mental health consultation in 23 states as well as internationally. She also served as an expert advisor for and continues to be involved with the SAMHSA Center for Excellence in Early Childhood Mental Health Consultation. She is a founding member of RAIN, a group of national experts advancing practice, policy, and research in early childhood mental health consultation. Ms. Johnston writes and lectures nationally on infant and early childhood mental health consultation. In addition to numerous articles, she co-authored a seminal test on the subject, Mental Health Consultation in Childcare, Transforming Relationships with Directors, Staff, and Families. So it's been a real true privilege to work with Kadija, and I welcome her today, so thank you.
And thank you, Evelyn and Meg. It is a reciprocally true pleasure to be with the two of you and the hundreds and hundreds of those of you who I have not met and cannot see, albeit at a now familiar technological remove. Thank you very much. As has been repeated now twice, this is the first in a series of 3 webinars devoted to the foundational elements of infant and early childhood mental health consultation. And from my perspective, there could be no better time to introduce or perhaps for some of you review the foundational principles and practices. As we wend our way through these uncertain and disorienting times brought about by the global community health, economic, and to some degree psychological and spiritual crisis related to COVID-19, we want to be able to rely on, to be guided and steady by our values and by tried and true practices. So the information that I'm going to offer today and in the subsequent sessions will be, I hope, just that. When we are firmly tethered and grounded in evidence-based practices, we are all better able to be positioned to make adaptations to our practice because we are assured of the solid conceptual footing out of which the changes come. So today I'm going to talk about both. I'm going to talk about and spend the majority of our time thinking about the elements of our practice that stay the same regardless of where you are implementing them, in centers or in family child care, and regardless on whose behalf, babies or bigger children. And probably most central today, what stays the same regardless of circumstances, particularly the current pandemic. So, as we all also need to think about the adaptations and additions to the present situation and what it calls for, both in terms of what I'm going to refer to as contours and content. We will be talking at the end of the presentation today about what adaptations we are making in relation to the pandemic. By contours, changes in contours, what I mean is that the way in which consultation is offered has and will likely continue for a long time to be different. Most of us are now providing early childhood mental health consultation from the same technological distance as we are participating in this webinar. Likely, this remote format will continue for some time. And by content, what I mean is that I'm referring to the psychological and material needs that have arisen as a result of the pandemic. The heightened sense of uncertainty and disorientation, experiences of loss and trauma that many are experiencing and that are accruing for children and their adult caregivers, including the early childhood education providers to whom we provide consultation, will be taken up toward the end of our time together. But in the beginning, I want to ground us first in a definition of infant and early childhood mental health consultation. I think it's important to begin by articulating, defining the terrain we're talking about. So infant and early childhood mental health consultation is perhaps obviously an indirect mental health intervention that pairs a mental health professional with other providers who are integral to the health and well-being of infants, young children, and their families, with the aim of promoting and, when need be, improving the social, emotional, behavioral, and relational health of those children. Through the development of partnerships, collaborations among the essential adults in very young children's lives, their parents and their providers, early childhood mental health consultation builds the adult's capacity to reflect upon and understand the invaluable influence of their relationships and the importance of their interactions on young children's development. And perhaps it will be a surprise, but mostly I'm going to be talking about, therefore, adults today, even though this is a focus on behalf and benefiting children. The approach that I will be talking about to infant and early childhood mental health consultation is one that I ascribe to and have developed. And I refer to it as a relationally focused, dynamically and equity-informed approach. This way of practicing is founded on and grounded in a conceptual quadrant. What I mean by that is it draws from the fields of infant mental health, from mental health theory, specifically psychodynamically informed theory in this approach, from professional consultation, and from principles of equity and diversity. So we're going to look first at how each of these bodies of knowledge, these foundational pillars, contributes to and informs the work. And for the sake of description, I'm going to artificially separate these constituent parts, but I hope you will see their synergy and that I will do a bit to braid them back together as we move along. So first, I'd like to start with thinking about what does professional consultation knowledge, skills, and understanding contribute to our work. First of all, mental health consultation is not a new undertaking. The modality was developed almost 70 years ago by Gerald Kaplan, and even in the arena of practice that we specialize in, infant and early childhood mental health, consultation has been offered for almost half a century. I'm going to talk later about its kind of rekindling and the new burgeoning, but it's important to remember that there is a body of knowledge and extensive literature on professional mental health consultation. And many of the cornerstone principles of the practice that Kaplan identified from the beginning apply today. So I want us to think about what are those principles that continue to apply, as well as what has been adapted over time. We still see understanding the ecological influences of a setting as an integral part of the method. And we also adhere to the established assumptions that the consultee's participation in consultation should be voluntary. Now, this is an interesting concept, the idea of voluntary, because while the consultant is always invited into a setting in early care and education by someone, often the director of the program, rarely does everyone in the setting have a say, or sometimes even an awareness of by whom or why the involvement was created. So one of the first tasks for us as mental health consultants entering an early care and education system is to be mindful of the very views about the reasons for our presence and whether participation is perceived as obligatory or optional. We have to work to help all feel as if they are included, even if they didn't invite us. By whom, we want to know, are we seen as an invited and therefore welcome guest, and for whom might we, at least initially, seem like an unsolicited intruder? Another historical and still important characteristic of mental health consultation is the notion that a consultative relationship should never be hierarchical. It is non-hierarchical. The consultant, of course, holds an expertise. We have expertise in early development and an expertise in mental health, but that is distinct from and equal in value to the expertise of our consultees. Beyond these characteristics that I've just articulated, which represent the original approach to mental health consultation, the principles that inform our modern day approach begin to diverge a little. Early conceptualizations of mental health consultation were really premised on a deficit perspective. What Kaplan articulated was that the first step in the process should be to identify what is lacking, where does pathology reside, and within whom does it exist, meaning the client, which in our case would be the child, or the consultee, in our case, which would be the provider of care. This is where I believe, this divergence is where I believe infant mental health, the field of infant mental health, has informed, and I believe in some instances actually transformed how mental health consultation is practiced. Because from an infant mental health perspective, based on infant mental health views, we think of development, of course, as transactional. So how does that influence our practice of consultation? Well, first is that dilemmas then are conceptualized not as residing within someone, but rather as developing in the intersubjective space between individuals. Even when the difficulty or disorder originates and emanates from one person, it is invariably expressed and exchanged in the interaction. As an example of that, what I mean is that an infant born prematurely may recoil from her caregiver's hug. So initially, that's an internal state, but that distress quickly becomes reciprocal as the provider, who was likely a ready partner, can feel rebuffed by the baby's extreme sensory sensitivities. In turn, the caregiver may begin to feel himself inadequate and likely less enamored of that infant for contributing to his feelings of inadequacy. Or conversely, a provider who herself struggles with depression based on a history that was punctuated by trauma, first from physically abusive parents and later at the hands of harsh adult partners, may be more quickly interpreting the inadvertent swipe at her face by a dysregulated toddler in her care as a sure predictor of that young child's predatory nature. This belief, this distortion on the part of the caregiver, influenced by her past experiences, of course, increases the likelihood that that toddler will begin to see himself in her light. So viewing relational contributors as the origin of these perhaps pathogenic or disordered effects and problematic interactions between providers and very young children, it's important to remember it's only one side of a transactional coin. From a relationally focused approach to consultation, we also rely on the interaction to alleviate or amend difficulties, meaning that solutions, even to concerns about a particular individual child, always include attention to how the adults in the child's life understand and view the behavior and are aimed at amending the adult's understanding of and interaction with the child. Mental health consultation informed by this relational focus, of course, also applies a transactional lens to the interactions between the adults in a child's sphere. We want to pay great attention to inter-staff and parent-staff relationships in early care and education settings, recognizing that the tenor of adult interaction greatly influences how children in a setting feel and how they behave. Adults who are at odds with one another in a child care setting have difficulty creating bridges of a communication over which children can easily cross. Stark differences among adults in child rearing practices can make it very confusing for children to figure out whose direction should they follow, resulting in a classroom sometimes characterized by chaos and disorder. So to address that kind of bedlam, consultation would need to, and should, I'm suggesting, focus on the relationship among adults. Building on these principles of infant mental health and professional consultation, our training in and understanding of mental health concepts makes it a very important contribution to the practice of mental health consultation. I want to, of course, recognize that there are many different theoretical orientations in mental health. I, like Gerald Kaplan, and perhaps some of you, consider myself and the practice I have developed psychoanalytically or psychodynamically informed. From a psychodynamic perspective that I think is important, it makes me consider unconscious motivations. I want to recognize in consultation the effects of internal as well as interpersonal conflict, and give a lot of thought to how defenses, the mechanisms human beings use to protect themselves from anxiety or overwhelming loss of self-esteem, how those are at play in the care that is given to children and how children might be internalizing those experiences. Of course, at this time of COVID-19, thinking about the ways that adults protect themselves from overwhelming anxiety and chaos is particularly important to attend to. As mental health professionals, we learn to examine and address, to lean into those difficult expressions in both adults and children. Because most, though, of our clinical interventions as mental health professionals are oriented toward pathology and usually take the form of treatment, we, of course, have to adapt our mental health understanding to consultative functions. As early childhood mental health consultants, mental health professionals apply their learning to better understand and ameliorate the difficulties of children who are the focus of child-specific consultation. But as I've been emphasizing throughout, is also that our mental health expertise is applied to the adults in children's lives. We work with parents and providers to figure out the meaning expressed through behavior. But we also need to know something about very young children's normative fears and how they differ from responses to trauma. We want early childhood mental health consultants to be well versed in the shape that defenses take in infancy, often evidencing themselves in sleep and eating difficulties. I think it's equally important, though, that our knowledge of mental health concepts are applied to adults. Consultees, the providers and parents of children, are approached with what I refer to as a double consciousness. What I mean by that is the provider and parents we consult with are viewed as both valued collaborators in the consultative approach of non-hierarchy, valued equal collaborators, and simultaneously viewed as clients. I don't mean that in the sense of being a patient in therapy, but as someone to whom the mental health consultant applies her clinically informed understanding of what motivates, what influences human behavior, and how change occurs. In addition to these interpsychic, as I've just mentioned, and then interpersonal influences on how adults view children and provide care, we also want to recognize that historical trauma, as well as ongoing injustices such as racism, xenophobia, sexism, ableism, and other forms of oppression, how they color how care is provided. Therefore, I have come to see, or maybe always thought of, early childhood mental health consultation as a platform for social justice. For me, that stand is brought to life by incorporating equity and diversity principles in my work. One set of principles that I ascribe to are the diversity-informed tenets for work with children and their families. This set of aspirational guidelines grew out of the work of the Harris Foundation Professional Development Network and grew out of a recognition on the part of those of us who are infant mental health professionals, the recognition that although great gains have been made over the 30-year history of infant mental health, that inequities exist still on a grand scale, and that particularly unacceptable gaps in access to and quality of mental health and early learning services exist for poor children, many of whom are African American, Latinx, and Native American. Also important to recognize is that in many instances, the providers of infant mental health services, like myself, are predominantly white, while many of the most vulnerable young children and families are children of color. So it seems obvious that in order to create a more just world for very young children, the field of infant mental health has to intentionally address some of the racial, socioeconomic, and other inequities in our society. And one step toward that aim is to deepen the field's commitment to diversity-informed, culturally attuned, and inclusive practices. The tenets, the diversity-informed tenets, were created as guidelines, a working aspirational document that puts forth such a vision of society in which all children, regardless of their status or race or family structure, will be recognized and well served. The first of the tenets is self-awareness, and I think grounded in the regular return to examine our own beliefs and biases. Then the first tenet guides us to probe and employ our privilege and our power when it is there to address inequities in the systems in which we work, with a recognition that all institutions within this society have been based on and structured around inequities, and that early childhood education is no exception. While all 10 tenets are critical, and I hope that all of you know about or will explore the diversity-informed tenets, I just want to mention two that I think in relation to early childhood mental health consultation in childcare are particularly seminal. The first is that diversity-informed practice recognizes that our professional training and particular expertise is complemented by giving credence to other ways of knowing and bodies of knowledge. This is the idea of recognizing non-dominant ways of knowledge. As consultants, what we want to do is to elicit and honor our consultees, the providers and parents and community members' contributions to co-creating classroom routines or responses to a particular child that are culturally congruent and promote healing from the perspective of that community's beliefs. And the other tenet I'd like to emphasize is the fifth tenet, honor diverse family structures, which reminds us, and I quote, that families decide who is included and how they are structured, and proclaims that no particular family constellation is inherently optimal compared to any other. Diversity-informed practice recognizes and strives to counter what has been an ongoing bias towards both idealizing and at times demonizing or blaming biological mothers. And we're trying to counter that, to not continue to overlook the critical contributions that are made to young children's development by other parents, second mothers, fathers, foster parents, and in our instance, particularly the contribution to development that is made by early care and educational providers. So I hope that by braiding these four conceptual cornerstones of equity, mental health, infant mental health, and professional consultation, that you begin to see the foundation upon which the practice is based. Consultation has become a really robust intervention with broad applicability. I want to also caution that mental health consultation can't combat all of the problems plaguing ECE. It shouldn't be seen as a panacea to paying early care and education providers what they deserve, or a panacea to all problems for young children. However, by incorporating these fundamental pillars of knowledge and skill, I think that what it's done is to expand the purpose and the purview of consultation. Initially, 10, 15, 20 years ago, the focus of mental health consultation in early care and education settings was really relegated to thinking only about a specific child who was struggling or sinking in the very environment that they were intended to be supported in, nursery schools or early childhood education sites. And while, of course, tending to the maladies or the difficulties of an individual child is still a central focus, child-specific consultation is a central focus of mental health consultation. What I want to suggest and what I've come to value and research is coming to confirm is that mental health consultation can have a broader benefit, an upstream approach. By aiming the intervention at the provider and the broader system of early care and education in which young children either flourish or flounder, consultation has the capacity to build provider capacity and to benefit the healthy development of all children and families served in those spaces. Expanding the parameter of early childhood mental health consultation, meaning expanding it to say this is a promotion, prevention, and intervention activity, I think has created a little bit of uncertainty about the focus of the practice. It's often that people feel it's hard to differentiate early childhood mental health consultation from other equally important but different quality enhancement activities. I hope that by my talking about how a mental health background influences the practice, that you start to feel and see some of the differentiation between mental health consultation and other quality enhancement activities. But I think this expanded purview of mental health consultation to include promotion and prevention, as well as intervention, can also cause a little consternation in those of us in my profession, those of us providing mental health. So why are we unclear about our purview? Well, I think partly it's because rarely is mental health referred to from a positive perspective. Think about when we say the term. When we say the term mental health, we're usually referring to its opposite, mental illness. Mental health services are rarely aimed at preserving positive states. And yet that's exactly what I'm suggesting is one role of mental health consultation, to combat the ill effects on mental health of all children in a setting by supporting higher quality programs and the capacity of the adults who work in those settings. I am convinced that it is not a necessary point of entry to come in only around the distorter or disturbance around an individual child. And don't get me wrong, I'm convinced of the benefits of consultation around an individual child. But what I'm suggesting is that the usefulness of mental health consultation is not limited to particularly acute situations, nor is it a crisis intervention solely. In this time of COVID-19, I think that consultation is perfectly positioned to deal with and support adults in children's lives and therefore children in a crisis, but it is not the primary or exclusive intention of the endeavor. I often use the analogy that we don't become concerned about the nutritional needs and put in a nutritional program in early care and education sites only at the point at which we identify signs of malnutrition in a single child. Similarly, it seems to me that we should not limit our sense of the importance of consultation to the particular child with diagnosable difficulties. Consultation can take a proactive approach to combat the ill effects of poor quality care on all children and create an atmosphere in which mental health of all children in a setting is protected. And that by providing and building provider capacity, what we do is we ensure the longevity of these salutary effects, because providers internalize and are able to generalize the learning made possible through consultation, thereby benefiting not only current clients in their care, but all future children in their charge. Increasingly, and viewed through an equity lens, another primary purpose of early childhood mental health consultation is to stem the tide of racially disparate expulsion rates. Many of you, or most of you, or all of you are likely aware of Walter Gilliam's 2005 study examining expulsion rates in state-funded preschool programs that revealed that children were least likely to be excluded from care when mental health practitioners were predictably present. Conversely, programs with no access to mental health services had the greatest rate of expulsion. So it really is adhering to this, what I consider proactive, equity-informed understanding of mental health and viewed through a transactional lens, that consultation doesn't aim to simply amend a deficiency in one child, but instead focuses on the interactions, the exchanges among adults and between providers and children, making the primary aim of mental health consultation to improve the quality of relationships in a system or setting by building the capacity, expanding the knowledge, addressing intolerances, and increasing empathy of all of the adults in a system. Mental health consultation is, as many of you, as evidenced by the number of this call likely, is as you know, it's burgeoning. Now more than half the states in the nation report that these services are occurring, maybe only in pockets, but there are now over 11 statewide efforts, and that is growing exponentially and quickly over time. The intervention, which began in early care and education settings, is spreading to all other systems where very young children and their families are cared for or reside. So given this expansion and growing interest in infant mental health consultation, I want to spend just a few minutes thinking with you about how do we understand the reasons for this growth? Why is it garnering? Why is this approach, which as you remember is old, is almost 70 years old, why is it garnering renewed and even wider spread attention? And I think that the growing knowledge, one, and appreciation of the lifelong impact of early experiences, early relational experiences, has heightened our appreciation and suggests that this intervention of consultation in this period in children's life, infancy and toddlerhood, is not only possible, but that that's the optimal place to intervene. You know what, maybe most of our grandmothers knew it innately, but neuroscience research and neuroimaging has confirmed, of course, that early experience is the architect of babies' brains, and that every domain of development is affected by early relational experiences. And who is contributing to those early relational experiences? Early educators are increasingly primary contributors to young children's first senses of themselves and views of the world, their mental health. Many children, the majority of children, over 60% of children in this country, by the age of 2, are in the care of people in addition to their parents. And many of them, by the age of 3, are spending 35 to 40 hours a week in the care of others. So that the contribution, that the relationships that early care and educators provide to children is not neatly bracketed off from their primary relationships. These are primary relationships that contribute to young children's overall development and specifically their mental health. Early care educators are also ideally positioned not only to contribute, but to recognize and respond to the mental health needs of very young children. And while providers are suitably situated to promote mental health, to assess and address the distress of young children and offer reparative relationships, and when needed, to make referrals to other appropriate services, I think it's important also to acknowledge the obstacles that early care educators face in their ability to create such relationships and offer such services. One of the factors complicating providers' capacity or capability to keep pace with the needs are the growing number of challenged and therefore challenging children with whom they're faced. You know, there's great variability in the percentage cited, anywhere from about 10 to 15% of preschool-aged children, according to their parents' and providers' description and report, regularly display behavior that is seen as problematic. It's important to recognize that these factors contributing to providers and parents reporting such large numbers of concern about very young children, the factors are themselves really varied. There are, of course, objective factors like domestic violence, substance use, parental depression, economic instability, which we are seeing growing right now in the midst of our pandemic crisis. And they are regularly referenced and highly correlated to children's distress and difficulty. And while it's important to credit objective factors and see that they impose challenge, I think it's equally important to acknowledge that subjective perceptions on the part of providers are powerful and also affect how children's behavior are experienced and labeled. Research indicates that teachers' reports of behavioral problems in young children vary depending on whether the child and the teacher are ethnically and racially similar or different, and that it depends on the percentage of children of color in a classroom as to whether a teacher feels like children are displaying difficult behavior. Racial disparities in preschool expulsion mirror those, not coincidentally, of incarcerated adults in this country, with African American boys being almost 4 times more likely to be excluded from preschool than their peers. While they make up only 19% of preschool enrollment, African American children compose almost half of the number of children suspended. Walter Gilliam's study found that the higher rates of expulsion were also associated with higher rates of teachers' stress and depression and less access to mental health consultation. Infant and early childhood mental health consultation has, I think, risen to national prominence in large measure because of its impact on reducing preschool expulsion. And of course, preschool expulsion is an extreme bellwether of racial, ethnic, and immigrant bias. We know that before children are excluded, they're plagued by numerous assaults to their sense of being, which is, of course, detrimental for everyone. But the experience of being seen as a threat or problematic is doubly dangerous for very, very young children who internalize those attributions about messages of who they are. And I want to say that there is some very promising data about mental health consultation's impact on these racial disproportionalities in disciplinary practices as well. Colleagues in Arizona at Smart Support are showing that mental health consultation is impacting these disciplinary differences. While in the beginning of consultation in the Arizona program, African American and Latino boys at the start of consultation initially were having the lowest scores on the DECA, lowest scores related to all other children who were the focus of consultation. Scores that said that they lacked self-control, that teachers felt less close and attached to these children, that teachers gave them higher scores in terms of conflict, expulsion risk, and negativity. Those teachers' perceptions, and it's important to remember that this is about perception of teachers, that these teachers' perceptions after 6 months of consultation, those same teachers reported the greatest positive growth gains in all measures for African American and Latino boys. And that growth in change in teachers' perceptions in a positive direction continued over the 12-month period that it was measured. I hope that very briefly reviewing those findings, as well as some of the others that you see in this slide, helps us think about the potential impact of mental health consultation. In addition to addressing racial disparities in disciplinary practices and expulsion, empirical evidence is also indicating that mental health consultation supports reduction in children's challenging behavior, that's especially externalizing behavior. And it also, that conversely, the practice is correlated to gains in pro-social behavior, including self-control, communication, interpersonal and play skills. And one study also has shown that parents were able to maintain work because they were not being regularly called to come get their child from child care because the child was suspended or excluded. These are evidence of change at the child and family level, and at the provider or program level, it appears that ECMH consultation contributes to improved communication among staff and between providers and families, that there is evidence that consultation enhances program quality by improving teacher efficacy. When my program first began 30 years ago, we looked at teacher efficacy, and on a scale where there were very gross, and by gross I don't mean yucky, I mean big, where there were large questions like, do you think that anything that you do in the course of a child's day, do you think that what you do as an early care provider has a difference on who this child will become? Before consultation, providers answered questions about their efficacy with a resounding no. Within 6 months of consultation, providers had changed their view about the impact that they have. I think very important to recognize that you have an impact on children's behavior. Why would you be interested in collaborating with a consultant or with a child's parents about thinking about what could change in your practice to improve a child's experience if you don't believe you have an effect? Enhancing program quality is also an outcome of mental health consultation. Improvement in skills in classroom management, interactions with children and their parents. And most important, given my definitions of the aim of mental health consultation, is studies are finding improved provider-child relationships. As early relational experiences are so closely tied to overall optimal development, I think this is a primary purpose and aim of consultation, to enhance the relationships, and that's particularly salient to our aim in our work. So for me, the question becomes how? What are the pathways of change? What are early childhood mental health professionals doing that are causing these kinds of changes through consultation? And there is theoretical and growing empirical evidence that actually parallel process is critical. For those of us in the mental health field, we premise a lot of our work on parallel process. But what is parallel process? I like to refer to it in the way that my mentor, Jeree Paul, identified it. She talked about a platinum rule, of course, premised on the golden rule, which we all know. But Jeree's platinum rule was, do unto others as you would have them do unto others. What, of course, she's saying is that how we treat, how we understand the experience of, how we show mutual respect to, and how we anticipate transitions with those with whom we consult will directly impact how they respect, anticipate transitions with, understand, and treat the children in their charge. What is being identified is that the mental health consultant educator relationship is an important, maybe the most salient mechanism of change in this intervention. So what are the characteristics that are being identified as equating to this positive relational change? It's been termed the consultative alliance by Annie Davis in some of her new work. And in that new work, it really reflects the extent to which the teacher, the early childhood educator, and the mental health consultant, how they perceive that they are partners, that they are mutual collaborators in an agreed upon endeavor. Another characteristic that has identified a positive relationship equated with the best child outcomes says that the relationship must be one of warmth and positive emotional tone. That providers tell us that what's important to them is that their relationships are bolstered by a consistency in the consultant's availability, mutually agreed upon goals, and the consultant's ability to take and hold multiple perspectives equally, not siding simply with a child or parent's perspective or advocating for one provider's views over the other, but the ability to hold and make meaning of multiple perspectives to enhance clear communication between the provider and the consultant, but also among the other adults in a child's life, and showing respect for the unique culture of each child care center has been seen as characteristics of these effective relational relationships. And lastly, is that what teachers identify as important about what mental health consultants do is a willingness to explore, lean into potentially difficult topics, particularly related to providers' individual mental health and interstaff or director staff or parent staff conflict and consternation. The quality of the consultant-consultee relationship predicted improvement in child-teacher attachment, in classroom climate, in educator-child closeness, and in a sense of educators' ability to feel satisfied in their jobs, therefore preserving the possibility that they would stay. So now what I'd like to do with those foundational backgrounds, I'd like to turn in the last several minutes to thinking about how do all of these foundational pieces that I've presented, how do these fundamental principles and understanding of the goals of consultation and the importance of the consultative alliance of the relationship between consultant and consultee, how do they inform our work in the current set of circumstances? So first, not that any of us are unaware, but let's describe what those circumstances are in terms of early care and education. I saw a report just yesterday from from NAEYC survey that right now, half of the child care facilities in this country are shut down. And of those that are open, the majority are operating at less than 1/4 of capacity. Those who are open or will begin to open will, of course, have to make considerable changes to their practice, particularly in ways that are relationally meaningful, meaning that practices like supporting parents to visit or come into the child care center will likely be curtailed. The idea that providers can maintain a lot of physical proximity or closeness to very young children will be minimized. What's also important to think about is that we are at a juncture where providers themselves are making pretty untenable choices between what they may feel like is their personal safety and economic survival. Parents are in similarly irreconcilable situations. As early childhood mental health consultants, it's probably necessary to acknowledge that it's unlikely that we'll be able to spend as much time, if any, in the child care centers in which we are used to visiting, meeting with providers, and observing children, relegating us, at least temporarily, to remote relationships. So we have to be thinking about what is our function in this new and more distal way of providing services. More distal at the same time that I would suggest that the need for mental health consultation services is increasing daily. And all of I want to preface this by saying that obviously I am as new to thinking about these adaptations as all of you. So that I hope that we can have a continued conversation nationally about how these adaptations are impacting the work and how we can share promising practices with one another. I think that one of the things we can rely on, though, is some of the fundamental principles that I talked about. Our mental health training teaches us that extraordinary circumstances like the ones we are in call for more direct action. So one of the shifts may be from a more reflective, eliciting space to one of consultants being more proactive about offering to stay in continued contact with those we consult with and with the families in their charge. But I also want to explore this maxim of direct action a bit as it pertains particularly to the situation we're in. The reason I'm saying this is because this crisis has a couple of unique characteristics that I believe really shape the action we should take. One is that unlike most crisis situations that mental health professionals are asked to respond to, we are not immune to the impact. We are experiencing it simultaneous to those we are consulting to, nor do we stand at a remove from this particular crisis. Now, this is not to suggest that everyone in the world or in the places we consult to is suffering equally. We know that inequities that already existed are becoming more marked. But what I am suggesting is that, to me, it's a persuasive reason to remind ourselves, meaning we are in this with people, with all others, that we have to, as mental health professionals, remind ourselves to rigorously practice self-reflection, to regularly assess our capacity to assist others, given that we may be experiencing the same distress and disorientation, and to stay particularly alert to the possibilities of projection. Since we are all somewhat similarly affected, I think this is a good time to be very thoughtfully able to employ, though, self-disclosure to use the ways that we might be similarly impacted as a kind of normalizing technique in consultation. I can tell you yesterday I was 15 minutes late to a consultation call that I have at the same time every month. And what I described once I recognized it myself to the providers was that my tardiness was due to my disorientation. I completely lost track of time, something that I'm finding myself experiencing a lot. I self-disclose that with the idea not just of excusing myself, but rather of having a point of connection with the providers with whom I was consulting. I think another unique feature of our current circumstances is that the action, the thing to do, is to not do. What I mean by that is that we have to do less. We are sheltering in place. We are removed from those with whom we can work. We have to titrate or temper our own and each other's wishes to take quick action. At the same time, I think this kind of inability, feeling hampered from doing, is leading to a heightened sense of impotence or a lack of efficacy on the part of mental health consultants, who I'm hearing feeling helpless or ineffective, and also by extension that the providers they work with are similarly suffering feelings of ineffectiveness. And these feelings of helplessness might lead us to take premature and ineffective action, like to want to rush to step foot in a child care center before it's clear that that is the place from which we can provide the safest and best intervention. Or the wish to take action might hold for providers to send out packets of dittos to families of infants and toddlers to make sure that their child charges aren't falling behind in their development. What I'm suggesting is we have to ask ourselves and our consultees first to reflect on what is driving the wish to act, at the same time as beginning to offer more concrete assistance than we might have in the past. We do so knowing that the underlying reason, the reason for helping providers think about how they can take meaningful action, is primarily to channel and convey adult anxiety, so they in turn can remain regulated for the children and families in their charge. An aspect of being more active also is to assist the adults in children's lives, parents and providers, in reestablishing predictable routines, beginning to replace transitional markers. An example might be offering as mental health consultants to call your consultees at the same time as the consultant would have previously met with a group of teachers in a classroom, or as providers in mental health consulting providers in my program have done, to set up regularly scheduled Zoom office hours to which individual consultees are invited, in an attempt to contribute to regaining emotional equilibrium. So for the last few minutes, let's talk about the changes in context, this remote way of relating. First, I don't know how many like me, but I was a bit of a Luddite before this abrupt change to providing all services through telehealth. I think that we want to remind ourselves and our consultees that this transition to remote ways of connecting was abrupt and unanticipated. And while we had little time to prepare for it, that we want to make sure to take some time now to assess how's it working and to co-create a mutual, congenial way and frequency of interacting. We have to revisit the agreements and contracts that we've established with our consultees. I think we also can all acknowledge with our consultees the limits of relating through technology. Obviously, there can be a loss of a sense of richness and real embodiment. And this idea of not being able to be body to body is especially meaningful for those who have worked with infants and toddlers, where the core of their connection is to be proximal, to interact non-verbally, to be embodied. we can also not just acknowledge the losses, but I think we make efforts, active, intentional efforts to compensate for some of these relational losses through heightened attention to staying present and to amplify emotional expressions over technological distances. And lastly, we want to pay equal attention to the differences in content as well as context. What are we being brought? What are we listening to from our consultees and from families with whom we are consulting during this time? We want to acknowledge the uncertainty of the times without evoking increased anxiety. Rather than relying on a future orientation, which is in other circumstances crucial, I believe, to engendering hope, we can also draw on the present and especially past experiences to engender authentic optimism. If we have a relationship with providers that we've been consulting with them over time, what I'm suggesting is we can remind consultees of a time that they made a difference in a child's life, or that they were effective, and that we remind them of their efficacy by holding those experiences with them. If we don't know what providers' accomplishments have been in the past, we can ask, you know, what has carried you through another time of feeling hopeless? Remembering, eliciting memories. Remembering serves as a refuge for all of us and often a source of refueling. We also want to anticipate and make room for feelings of anxiety, loss, disorientation, and grief. These feelings, we want to watch for them. They may be expressed directly or through behaviors, but we also want to acknowledge they may be being defended against. We may see withdrawal, providers who no longer want to meet with us or who seem listless. And we have to acknowledge that there are also pragmatic and other reasons besides interpsychic ones. People are absolutely exhausted and they are very busy. But we also want not to discount that defenses may be a reason for the withdrawal, while making space for exceptions and expressions and creating a holding environment. This is also a time when we want to shore up people's defenses so that they can continue to function in the midst of uncertainty. And lastly, we don't want to overlook opportunities. In talking to mental health consultants from around the country and around the world during this time of COVID, I have seen many opportunities and accomplishments. Freed from the relentless pace of childcare, many early childhood mental health consultants are finding that providers are making more space for reflective conversation and more time for team meetings. Others, consultants have been invited, they're telling me, into activities from which they had previously been precluded, like meetings with a worried parent or helping a very distraught director who previously couldn't make time to talk with the consultant. These encounters afford opportunities to demonstrate our usefulness, partly through, of course, offering information and suggestions, but primarily through offering the relational qualities I identified earlier as equated to mental health consultations efficacy. We can capitalize on these relational moments afforded by crisis by beginning to make meaning of the shared experiences and to start to think with our consultees now about how to sustain the gains that this time has afforded as we move into the next phase. And so I think in terms of thinking about moving into the next phase, we should stop there and move into the next phase of this morning's happening. We will open it up to questions that I've seen arising in the chat as we've gone along after a moment of a request and reminder by Meg. So thank you.
So this is Evelyn Blank, and I just wanted to remind people to please fill out the evaluation, which you will find in your chat box. We're very interested in getting your feedback. And Kadija, that was wonderful, and we have some very interesting questions here that I'd like to pose at this point. So first of all, there was a comment that was made by one of our infant toddler mental health consultants on the slide of why is infant and early childhood mental health consultation spreading? And the comment was, I feel like the long-standing stigma of mental health also impacts the if and when people reach out for help. People often wait until they are in full-blown crisis to call for help. Sometimes I feel that if mental health consultants and professionals were inclusive in our educational systems to begin with, as a part of all children's well-being, that would normalize our presence in programs and be seen as a way to preserve mental wellness and not just to respond to mental illness. So I'm wondering if you could comment on that.
Well, my comment is here. I hope that comment is in line with my analogy around the inclusion of nutritionists in early care and education settings, not only at the sign of malnutrition in one child. So I think that this is a place where we need to work as a cohesive mental health community to begin to first see ourselves, as I mentioned, see ourselves as people who can intervene along the promotion, prevention, and intervention spectrum. This, to me, relates to how we begin to include teaching in higher education institutions, how we begin to include teaching around infant mental health, but also to include teaching in higher education institutions around consultation, so that mental health providers begin in their educational experience to see themselves as people who can be included in all ranges and all settings. And then advocacy also to the places to whom, the settings in which we are going to consult. I can tell you that when I started mental health consultation now a little over 30 years ago in my own community, that I went out to the range of early educator providers, center-based and family child care. And I was very explicit in giving the message that, exactly as the person who asked the question suggests, that there was not a need, nor was it even preferable, to wait until there was a crisis or an individual child who rose to the level of concern. And that I stressed the idea that any of us are actually more beneficial once we have known the person to whom we are trying to provide assistance and help. I also talked about the ways in which mental health consultation could address broader spheres of influence, like how routines are managed and understood in a setting, and how adult relationships, as I've spoken about this morning, how adult relationships can be attended to in such a way that best support all children in a site. And even with those introductions, I just want to say that when we first started mental health consultation at my program 30 years ago, every single one of the people who called to request consultation initially requested it around an individual child, and several of those children had been expelled from their programs before we were able to enter. So I say that not as a hopeless, but a hopeful example, because now, over the course of our inculcation into our community, meaning that all providers of early care and education, as well as providers in family child care, home visiting, homeless and domestic violence shelters, and our residential substance abuse treatment programs in the San Francisco Bay Area, they are aware of and receive mental health consultation, anybody who wants to, in an ongoing way. And by establishing it as an ongoing preventative and promotion effort and having it funded to provide promotion and prevention, we are now inculcated in communities where it is seen as an expectable partnership between mental health and all of the other necessary providers in young children and families' lives. So thank you for that opportunity to re-emphasize that possibility and the importance of not only being able to provide the service at a moment of crisis.
Said that you discussed your early childhood mental health consultation approach as being relationally focused, dynamically, and equity informed, which I thought was really a great framing. And you discussed also that, you discussed that it is also psychodynamically informed. Can you speak a little bit more about the specific approach that relates to infant and early childhood mental health, and specifically how the approach is best used through telehealth or virtual consultations, where it's hard to have face-to-face contact during this pandemic?
I hope I touched on that and recognize I touched only a little bit at the very end. But I think about the ways in which something that actually many in the psychoanalytic community, obviously they're thinking about it in terms of treatment, and we have to make adaptations to consultation. But there's a lot of literature and videos being put out talking about telepresence, a term that I'm coming to engage with. And really what I have learned about through my very recent and nascent studies is this idea of the ways in which relational reminders, for one, if we're working with providers that we had a relationship with, that one, we want to, as I spoke briefly about, to remind people of some of the relational foundations that were created when we were in person. And I don't know how all of you are experiencing it, but I'm finding that when relationships pre-existed, there has been an ease in making this transition to telehealth in a way that I hadn't positively anticipated. But the other thing about technology that I've begun to learn is that there are built-in ways in technology that in order to make it appear seamless, what they actually do is the technology taps down our affective expressiveness. So I think the intentionality of what I refer to as amplifying affective expression, which is probably one of, I don't know if all of you, like many I've been talking to, feel why am I so exhausted at the end of a day on Zoom? That some of this is that we are intuitively amplifying our expressiveness and our attentiveness. So while that takes additional effort, I have seen the very salutary effects of being able to maintain a relationship with providers over telehealth. I think the next phase, and some people are already beginning to introduce in those centers that are in those child care centers and family child care programs that are open, to begin to introduce technology as a way of observing children and families in the site. And I think there's much that we have to consider from the policy as well as the practice perspective of how we begin to incorporate technology in the observation of children in those sites.
Very helpful. So there was another question. Where can consultants get training in the diversity tenets? Do you recommend that child care providers and teachers receive this training as well?
Yes. Yes to all of the above. So what I can do, and I realize I did not put it into the slide, but I will make sure that the website, which is an open website out of the Irving Harris Foundation for the Diversity Informed Tenants, I will make sure that that is on the TTAC website, if that seems like the best way to make it accessible to everyone on this call. And through that website, you not only can get the full downloadable 10 tenant descriptions in now, I believe, both Spanish and English, but you can also read open sourced articles that have been written about the tenants, and most importantly, in relation to the question, you can request training in the diversity informed tenants for your organization and for the organizations that you consult to.
Terrific. So we have time for one more question. I did want to remind people to please fill out the evaluation. Can you give some examples of shoring up of defenses as part of consultations?
Wonderful, a wonderful question. I think that shoring up defenses relates to what the particular defense is, but that part of what I'm thinking about is that if there's perseveration in talking endlessly and kind of rotely about the worries and the inabilities that are brought forward by this pandemic, that I'm not suggesting that what we do is to ask people to stop the ways in which they are finding themselves acting, but that what we might do as a way of shoring up defense is to try to contain anxiety and look at what people are already using, so that if one of the things that people are using, not consciously, but if one of the things that we notice people are doing is staring off into space when they're on the Zoom call, or easily distracted, which technology allows us to do, or not engaging by either not meeting us at an appointed time, that what we might want to do is to acknowledge, not even that we acknowledge it to the other, but acknowledge the need for some distance from what might feel emotionally draining. So for instance, I've started to institute that every meeting that we have, we're going to end 5 minutes earlier than we would have, but that I'm suggesting as a way of consolidating and shoring people up, that we use those 5 minutes in an agreed upon way, so that before we end a call, I'm asking each person, what will it be that they will do in that 5 to 10 minutes that will ensure that they can re-regulate, that they can organize and calm themselves, that they can take what we've done together and make use of it, and that they commit to that to themselves and to one another, and then do that individually. That's just one example of a way of shoring up a defense.
Thank you so much. This has been incredibly rich, timely, and informative presentation. And I want to remind everybody that this is part one of a three-part series. And please, we do encourage everybody to please take a minute or two to fill out the survey. We really want your feedback. We want to inform it. And again, thank you so much, Kadija. This has really been so incredible. Thank you.
Thank you very much. And thanks to everyone for your participation and involvement in a way that I know can often be difficult to maintain at a time when we all are struggling. Take good care and be safe. Bye-bye.
Thank you. Be well, everyone. Thank you.